Good afternoon. Welcome everyone to the second meeting of the Senate Committee on Health and Human Services for the 82nd Legislative Session. Madam Secretary, please proceed to call the roll.
Senator Lang. Here. Senator Nguyen. Senator Stone. Senator Titus. Chair Donate.
And I'm present as well. Please mark Senator Stone and Senator Nguyen present when they arrive. All right, thank you so much. So good afternoon, everyone. Today we have a hearing on Senate Bill 45 along with presentations from the Nevada Medicaid Managed Care Organizations, or MCOs, and the Nevada Hospital Association. Given that our senators are still not here, we're going to change the order of today's agenda. So we'll start off with the presentation from the Nevada Hospital Association, followed by our bill hearing, and then we'll end with the MCOs. So before I go ahead and begin with the presentations, I just want to make a few housekeeping announcements. As I mentioned, the agenda items may be taken in a different order than listed, and they may be combined for consideration. We ask that public comments be kept to 2 minutes so that everyone interested in speaking can be accommodated, and we ensure that we can get through the agenda in a timely fashion. Speakers are urged to avoid repetition of comments made by previous speakers. You may also submit public comments in writing, either in addition to testifying or in lieu of thereof, and written public comments may be submitted before, during, or up to 48 hours after the meeting adjournment. If you wish to testify, you can sign in at the table by the door and provide a business card to the committee secretary. If you do not testify, you may also want to sign in so we can have a record of who you are. When testifying, please make sure that you turn your microphones on to speak and off to listen. We have listeners and viewers in Las Vegas and online, and recording this meeting as it will be available to the legislator's website. And as a reminder to all those who set to testify, pursuant to NRS 218E, it is unlawful for any person to willingly misrepresent facts when testifying before a legislative committee, and a person who knowingly does so is guilty of a misdemeanor. Anyone who wishes to receive copies of the committee's exhibits should go to the Nevada Legislature's website, and you may also request copies from our committee manager. And finally, please turn off your electronic devices, especially your cell phones and laptops, or put them on silent mode as needed. So looks like we have two of our colleagues that have just arrived, but Mr. Kelly, I promised you that you would go first. So please proceed when you're ready, sir. Mike, there you go.
All right, I'm the newbie, so please bear with me. My name is Patrick Kelly. I'm the CEO of the Nevada Hospital Association, and I want to thank you for the opportunity to present before the committee. I wanted to start off with just providing a kind of an overview of where things are in terms of how many hospitals we have in the state, some very basics. So we have 68 hospitals in the state, and 3 of those are federal facilities. We have a hospital at Nellis Air Force Base and 2 veterans facilities, one in the north and the south. And as you can see, out of the 68 hospitals in the state, we have a mixture of acute care hospitals, behavioral health, critical access, and long-term acute care, which is often referred to as LTACs, and rehabilitation hospitals. We employ over 34,000 people, and that payroll generates $4.3 billion in economic activity in the state. We have over 360,000 patients, and we have over 1 million emergency department visits each year. Now, I was asked to provide information about community benefit, and before I get started, I do want to tell you that we don't collect that information. So we're getting that information from the hospital annual report, which is information that's submitted to the state. And under state law, hospitals with 100 or more beds report to that. So you're only going to be hearing about 19 acute care hospitals. But I want you to know that all the hospitals provide community benefit and services to their communities. We just don't have that captured in this presentation. So when you look at under-reimbursed, we provide $1.3 billion in care, and that is the people on Medicare, Medicaid, and the uninsured, and underinsured who come to our hospitals who cannot pick up the full cost of the services they receive. So to give you an idea, Medicaid pays about 53% of the cost of care, and I just want to note that when we talk about Medicaid rates, please keep in mind that over the last 20 years, there's only been a 5% increase in Medicaid rates to hospitals. And I'm not saying 5% each year, I'm saying 5% over 20 years. And then the Medicare pays approximately 87% of the cost. So we have a good number of people that when they come in and receive services, they will not be covering the full cost of their care. We also provide health professional education. So we have medical students that come into our hospitals, nursing students, any kind of tech, somebody receiving certification usually needs some training within the facility, and we provide that. And we also provide health services to the community through education, clinical support services, and things of that nature. In 2021, we contributed over $500 million in capital improvements to the state to enhance access for people to receive services. Now, I wanted to talk a little bit about what the current status of hospitals in the state is, but to do that, I'd like to just step back for 1 second and talk about last year because it really has an impact on where things stand. So believe it or not, last year at this time, we had a COVID surge in the state. And that's hard to believe because we kind of all think COVID's over, but it wasn't that long ago. We also in the fall had a surge with respect to respiratory illnesses. You probably saw a lot about children and RSV cases, but we also had a lot of adults who came in with respiratory illnesses too. We were quite busy. And during the course of the year, we saw incredible inflation throughout and also shortages. So all that leads to this slide, and that is half of the hospitals, acute care hospitals in the state had a negative operating margin for the first 3 quarters of last year. We don't have the fourth quarter in yet. I don't expect it to be much better. So we're looking at half the hospitals who are really having some economic struggles. What were the cost drivers in that? Drug costs were definitely a component of that. To give you one example, at one point there was a shortage of CT and MRI contrast dyes. And prices went from a normal $700 to up to $7,000 if you could even get the contrast dye. So there were crazy things that happened. We also had supply costs. When you go to the gas station and you see the price of gas goes up, you probably don't think, gosh, healthcare supplies went up. We have so many products that we use that are made from petroleum that it just caused prices to go up. So, you know, when the nitrile gloves that we wear when we see each patient, in the last 3 years, they went up over 200%. The syringes, the plastic syringes with the needle in it, those went up in price. The IV bags are made of plastic and the tubes that go through, those all went up because petroleum prices increased. We also had the baby formula shortage. That was big in the news too, and we were affected by that. Basically, whenever there's a shortage, our costs go up. So the last thing I want to talk to you about is labor costs, because that's a really big component of hospital care, because believe it or not, 60% of our costs or more are related to labor costs. So let me just kind of show you what went on there. We did a survey of our hospitals and asked them on July 1st of last year, how many open positions did you have? And with respect to RNs, we were over 2,300 open positions, LPNs 188, and CNAs 616. Now keep in mind, this is only hospitals. The rest of the healthcare delivery system was experiencing difficulties too. So as a result, we had to go out and hire traveling nurses, and that's incredibly expensive. We pay 2 to 4 times the amount of more for traveling nurses than we do for staff nurses. But we do that because we need to keep the hospitals staffed as much as we can and give a break to the nurses we have. If you've ever wondered what the RN wages in the state would be, the average is $89,700, LPNs of close to $60,000, and we were ranked by Becker's as having the 6th highest RN wage when adjusted for the cost of living. So we do pay our folks very well. Also, if you go onto the Bureau of Labor and Statistics, you'll see that we're in the highest wage category in the country. So we're there with New York, Massachusetts, California. So we are very competitive in that regard. But here's one of the things that's really been perplexing for us. We are not able to discharge our patients timely. And so this all started with the COVID surges, and it was difficult because everybody was backed up. But the problem is this has continued, and that's kind of what has surprised us to a great degree. So in December, on average, we had 517 patients in our hospitals who were medically cleared for discharge by their doctors that we could not place. And there are a variety of reasons, but one of the main reasons is the post-acute providers to whom we would discharge those patients didn't have the nurses to staff. So they had beds, but they didn't have the nurses to staff them. So, you know, I go back to that is one of the big problems plaguing the healthcare delivery system at this time. You asked what would be some of the needs we looked at. You know, I have to tell you, nursing is one of the big things. I mean, we've just got to figure out how to address this shortage in the state, because as we look out, there's really nothing that we see on the horizon that's going to solve the problem or it's going to get better. We're going to have a lot of retirements coming up based on the ages of our nurses, and that's of great concern. We also encourage you to pass policies and laws that encourage physicians to come to Nevada to work and not to discourage them, because we really are in desperate need. You can see that we have all sorts of access problems. I failed to mention that I passed out this book that, you know, being fairly new to the state, I went through and during the course of the year, I saw different statistics that just really surprised me. And I thought, you know what, it would be nice to have all those in one place and having to go through, you know, stacks of reports. So that's what we tried to attempt to do here. And we pulled a lot of reports from UNR and from some national publications just to paint a picture for you of the overall healthcare delivery system in the state. And finally, I'd add that we'd ask that there would be no additional costs or burdens placed on hospitals, because as you saw, we have a lot of hospitals that are having financial issues, and we just ask that you help us get through this period. You know, when COVID first started, the federal government came in with a lot of money to help us out, but that money dried up quickly. And so, you know, for the past year, we have not been getting the kind of money that we need to be able to sustain our operations as we would like. So I would just want to tell you, we're always grateful for everything you do. We're appreciative that you come and serve here in the legislature, and we look forward to working with you through the course of this year.
Thank you so much, Mr. Kelly. Any questions from the committee members? Dr. Titus?
Thank you, Mr. Chair, and thank you for the presentation, although somewhat grim. It's real and situation. One thing that we experienced, certainly in my little hospital, is that we had the nurses, but they saw that it was definitely better to quit the hospital and go be a traveler nurse. And so do you have an estimate on how many nurses, do you have any idea how many nurses actually did that?
Pat Kelly for the record. We don't have information on that, but it was a huge problem. And, you know, that's one of the reasons I wanted to show you the wages that we're paid and where we rank in the country, because we're high to begin with, but, you know, you can't compete with those traveling wages. They're just so much higher.
Yeah, and I just want to emphasize one of the things that we looked at, as you mentioned in your last statement, about the workforce and people leaving the workforce. And one thing we found in COVID, certainly across the spectrum in healthcare, especially if you were near the age of retirement and you could, people did, and we don't see those folks coming back to the workforce. We're looking at bills that include the nursing compact bill, so we could maybe get some nurses licensure here quicker. Is that something that the Hospital Association would support?
Pat Kelly for the record. Yes, Senator, we do support that. I want you to be clear, that's not going to solve the nursing shortage, but when we have surges, it's really important. And I'll tell you, it showed up during the RSV, because here's the weird thing that happened. The East Coast started to have RSV before we did. And so all those hospitals started contracting with pediatric nurses, and that's not a big pool of nurses to begin with. So they had them all tied up in 3 to 6 month contracts. So then when we started hitting here and we tried to get pediatric nurses, it was difficult to recruit them. And some of the traveling companies said, you know what, we're kind of putting Nevada down on the list because it takes longer for us to get them placed and up and operating, whereas if they go into a compact state, they can start working the next day.
Right.
So we weren't viewed extremely favorable.
Good to know. One of the other things, a solution to healthcare providers is making sure that there's partnerships with the hospitals when we look at graduate medical education or training of our lab techs and working with the university. So just want to hear some reassurance that the Nevada Hospital Association is certainly ready to partner, and it will continue to partner with the university systems, the school, professional nursing, to make sure that we can get slots for those, whether they're a social worker, whether they're a nurse or a lab tech, that make sure that it's a statewide, everybody helps everybody, and make sure we can get these folks educated here in the state of Nevada.
Senator, that's a great point. Pat Kelly for the record. The one thing that we want to help, but the problem we run into is everybody wants to come into the hospital during the exact same hours. And we've got to work together to come up with a system where we can bring them in at different times during the day so that we're not congested. And the tighter the nursing supply is in the hospital, the harder it is to bring nurses in to train. But, we all have to make an effort to do that, and we will.
All right, thank you. Thank you for the question, Chair.
Thank you, Dr. Titus. Mr. Kelly, on the slide regarding under reimbursed healthcare, the 1.3 billion number, is that for 2022 or is that?
Sorry, Senator, Pat Kelly for record. I believe it's 21.
Thank you so much. And I'm sure we'll have more conversations later on during the session about uncompensated care. Senator Nguyen.
Thank you. I just have kind of a follow-up to what Senator Titus had mentioned about the nursing compact. During the pandemic, we essentially were in a situation where we had that flexibility to bring in nurses. And as you mentioned before, we still had shortages. Are we still under that COVID kind of protocol where we're able to bring in nurses without the compact right now?
Pat Kelly for the record. That's an excellent point, Senator. So here's where we are. During the pandemic, Directive 11 allowed us to bring in nurses very quickly. That's gone. Now, when we had the issue with the pediatric nurses, the State Board of Nursing was fantastic in helping us really streamline that process and get them in. So we're grateful for that. But we don't have the flexibilities that existed under Directive 11.
Senator Nguyen, did you have a follow-up or are you good? Any other questions from any committee members? Senator Stone.
Thank you, Mr. Chair, and thank you, Mr. Kelly, for your comprehensive state of the hospitals in Nevada. Just a few questions. Can you just let us know the impact of the low Medicaid fee and the impact it's having on our hospitals here in Nevada?
Pat Kelly for the record. Thank you, Senator. That's a very important question, very important point. That is a big issue. I mean, it leads to a lot of cost shifting in the state, and it's really something that needs to be addressed. We are working on that. We've been working for quite a while on the Medicaid provider fee program for hospitals, and we're getting very close to that. And I just want to give a praise to the department because they've been a fantastic partners in working on this. But when you start getting into this and you have to deal with federal regulations, holy mackerel, there's always one that stops you from going down this path, and you have to, deviate and go to the others. But I'm optimistic. I think we're getting pretty close, and that'll have a huge impact. It'll get some of the hospitals that are in financial trouble. It will make a big difference for them.
Yeah, I'm concerned about the last 3 quarters you talked about where the hospitals are operating at a negative. I think that would have a positive impact and also allow for greater access by physicians that are willing to take it. What do you think is the largest hindrance to attracting nurses to Nevada? You mentioned that we're one of the highest payers of nurses in the country. So what's the stumbling block?
Pat Kelly for the record. I think our issue is that we're not graduating enough nurses at this time period. So, it's been interesting. I've heard people talk about, well, this has been a problem. Nursing has been a problem for 10 years in the state. And then I've actually read documents where it goes back 15 years in the state. The problem is this is just cumulative now. And the COVID just caused it to snap. And as a result, we're going to have to produce more nurses. And we're looking all sorts of different ways to do that, whether it's 2-year RN programs, whether it's bringing in foreign nurses, whatever we can to address the issue.
So those are great ideas, and I think that the legislature has your ear as far as boosting the number of slots that we have for nurses in Nevada, but if we're going to have an immediate effect of satisfying the nursing shortages, I think we're going to have to be much more innovative in the state of Nevada. I'm sure you've seen the concept that the state of Arizona had employed during COVID when they had the shortage of not only nurses but physicians with occupational licensing recognition. It may be a fast way to bring nurses into the state that would like to come here but might find some regulatory or bureaucratic hurdles in the way. So I would love to chat with you more about that offline. Lastly, I know in my neighboring state, we had a major problem with homeless populations that were occupying emergency rooms and not freeing up space for people that truly were sick. How has the homeless situation affected hospitals here in Nevada?
Pat Kelly for the record. Senator, we're always concerned about the homeless folks in our communities. And yes, do they sometimes use the emergency room as a shelter or an opportunity to receive meals? That does occur. You know, when we have a person who's been seriously ill and then we have to discharge them, it goes back to this whole issue of we're having difficulty discharging patients to post-acute care. So it all comes in, and I do think we need to sit down and have a really strong conversation about the homeless population, how we can best serve them.
Thank you so much, Senator Stone. Mr. Kelly, what's been the response from the hospitals regarding the so-called patient dumping that has resulted within the last month or so? Has there been a further discussion at the transition of care between different hospital systems? Is that something that has been an internal conversation to that response? I know that's a potential legislation that folks will be introducing. So can you provide some insight to that?
Pat Kelly for the record. Senator, I think everybody in the state saw that video and was very concerned about it. And yes, there are a lot of conversations taking place with regard to that. So I'm hoping, you know, we can always do better, and this is an area that I hope that we can really focus on and do better.
Sounds good. Thank you so much. And do you have in the slide about the trends of hospitals that operated at a negative net
Operating margin.
Yeah. Do you have the trends as to what that was prior to COVID-19? Are you able to provide the documentation, or do you have that off the top of your mind?
Actually, I had prepared a chart the year before, and we were around 1/3 of the hospitals had a negative operating margin of 1% or less. Now the 1% doesn't make a whole lot of difference in that. But yeah, so we are definitely increasing. But I will also say that when we're talking about 50%, that's not uncommon nationally too, because the whole healthcare delivery system has really struggled in the last couple of years.
All right. Thank you so much. Any other questions? Senator Lang.
Hi, I just have a question about the traveling nurses as well. So I think it kind of compounds the problem because we're paying really well already, which is unlike many industries in Nevada. And yet we have traveling nurses that are coming in and making way more money, which cuts the opportunity to hire more full-time nurses, is what I'm thinking. Is that true or not true?
Pat Kelly for the record. Senator, I think we would hire any nurse that was qualified who came to us. I mean, I've talked to even folks in the rural hospitals who really watch their staffing because of limit, and their policy is if someone moves to town and they're a nurse and they're decent, we're going to hire them. I mean, that's how desperate we are. But to your point, the money is leaving the state that we pay to those traveling nurses, and that could be spent here and rolling around in the economy. I mean, one of the great economic development activities that we could do right now is to increase the number of nurses, because we could really have a bigger economic impact in the state.
And do you find that more people are trying to be traveling nurses because they do get paid so much more? And that's why it's hard to attract people into the full-time positions that you have available?
Pat Kelly for the record. Senator, what we're seeing now is less people are going into traveling because the traveling rates have come down. During the surges, I mean, you're paying 4 times as much. I mean, we're still paying like twice the amount. So the incentive isn't as great. And I think some people are just kind of getting a little tired of traveling. I mean, they had an opportunity to make a lot of money in a very short period of time. And, that was the choice they made.
So then in that vein, have you seen more people Have you seen more nurses transitioning from traveling into the full-time positions? Have you noticed any trends at all?
Pat Kelly for the record. I think we're seeing a little bit, but nothing that's overwhelming at the moment. You know,
Okay.
hoping people will come back home.
Thank you.
Thank you.
I think that concludes our round of questions. Mr. Kelly, of course, we're always a pleasure to have you here. And, I think a lot of us can say that the hospitals provided valuable service during COVID-19 and continue to do so. So thank you so much for coordinating this presentation and for being here today. So thank you. And I'm sure we'll have, if there's any follow-up questions, we'll be sure to communicate them to you.
Thank you. And thank you very much for the opportunity to present.
Yeah. Thank you so much. With that, we will go ahead and move on to our next agenda item, which is opening the hearing on Senate Bill 45. So I'll go ahead and open the hearing on Senate Bill 45. This bill establishes the amount of personal needs allowance provided to certain recipients of Medicaid. With us today, we have Ms. Fran Almaraz, who is the forum president. So please proceed when you are ready, ma'am.
Good afternoon, and thank you, Chair Donate and committee members. My name is Fran Almaraz, and I am proud to serve as the president of the Nevada Silver-Haired Legislative Forum, representing Senate District 10 as a foreign member. I am pleased to present Senate Bill 45, which would increase the monthly personal needs allowance for certain Medicaid recipients residing in skilled nursing facilities so it is equal to the amount for Medicaid waiver recipients living in group home settings. With me today is Patrick Ashton, policy analyst from the Research Division of the Legislative Council Bureau, who provided, together with his colleague, Ashley Kalina, nonpartisan staffing services to the forum for the last interim. Additionally, Marie Coe, long-term ombudsman of the Aging and Disability Service Division, is attending this hearing to answer questions from committee members requiring subject matter expertise. I also want to point out an exhibit provided to the committee which should be uploaded on Nellis. It is a template letter from the Department of Health and Human Services, Division of Welfare and Supportive Services, sent to group home operators in Nevada last fall, informing them about the increase in supplemental Social Security income payments for 2023. As a brief overview, the Nevada Silver-Haired Legislative Forum was created in 1997 to identify and act upon issues of importance to aging persons. The forum strives to promote inclusive government by directly involving seniors in the legislative process. It is comprised of up to 21 members, 60 years of age or older, nominated by state senators for appointment by the Legislative Commission. Foreign members participate at public meetings, ask questions of the presenters, and discuss agenda items for future consideration. In the past, the forum studied senior issues such as respite care for caregivers, improvement in the provision of long-term care services, protection of seniors from abuse and neglect, and homelessness among aging seniors in Nevada. The forum may submit one bill draft request to each regular legislative session. During the past interim, forum members participated in 5 meetings and considered topics related to climate change awareness and resilience planning for senior citizens, potential for increased penalties for scams and fraud that target seniors, long-term care challenges and opportunities, assistance for seniors with dementia and their caregivers and families, and community services and assistance for seniors in need in Nevada. At our forum meeting in June of 2022, members learned during a DHHS presentation that there are 2 care options for long-term services and supports for certain Medicaid recipients, including seniors, institutional care, and home and community-based services. Institutional care, for instance, seniors residing and receiving care in a skilled nursing facility due to their high level of care needs. Home and community-based services allow for individuals with a significant physical and/or cognitive limitations, and who are at risk of being admitted to a nursing facility to continue living in their home or a home-like setting, such as a group home, to remain integrated with the community. We also learned that Social Security Act provides for Personal Needs Allowance, or PNA, for Medicaid recipients residing in nursing facilities and group home settings. That is, if a Medicaid recipient is living in either of these settings, the Social Security Act requires an allowance to be deducted from their monthly income to reserve some funds to cover costs of care not reimbursed by Medicaid. The rest of their monthly income goes to the nursing facility or group home for room and board. These Medicare recipients depend on the PNA for items such as clothing, grooming needs, toiletries, snacks, writing utensils, stationery, essential personal items, and other incidentals. Federal statute sets the minimum monthly PNA amount at $30. States can allow a higher monthly PNA than the required federal minimum. Here is the challenge that we're looking at in Nevada. Seniors receiving Medicaid and living in nursing facilities or group home settings receive a PNA, but differing rates of $35 and $149 respectively. Overall, the difference in the PNA between Medicaid nursing facility residents and Medicaid home and community-based services clients in a group home is currently $114 a month. In other words, a senior living in a group home receives an allowance over 4 times higher than a senior residing in a nursing home. Based on information provided by DWSS, the PNA rate for residents of nursing facilities has not changed since 1991. Nevada is one of the 7 states that have maintained a PNA rate of less than $40. This means, for example, seniors residing in a nursing home must save their PNA for several months to replace basic clothing items, and this issue has only worsened with inflation increasing the cost of everyday items over the last 32 years. In contrast, seniors living in group homes and receiving Medicaid, home, and community-based waiver services have their PNA annually increased on the annual Social Security Administration cost of living adjustment. Beginning in January 2023, these recipients receive a total SSI of $1,305 monthly, which is split as follows: a federal payment of $914 and a supplemental state payment of $391. Waiver recipients may keep an allowance of $149. The remaining $1,156 go to the group home operator to cover room and board costs. The PNA is increased proportionate to the SSI COLA adjustments. For instance, the COLA for 2023 increased the PNA for these group home residents by 8.7% from $137 a month to $149. I would like to give you 2 examples of other states that tied the allowance increases of nursing home residents on Medicaid to the COLA by the Social Security Administration. Minnesota established a monthly minimum amount of $45 for PNAs and requires COLA increases by the same percentage increase as the federal benefit rate. Washington set the PNA at $72.05 for clients being served in nursing homes in residential settings and is increasing the allowance by the COLA percentage. In 2022, Washington State Legislature passed a bill that allows Medicaid recipients in long-term care settings to retain up to 300% of the federal benefit rate, which is $2,523 to cover personal and household expenses. Let me briefly summarize Senate Bill 45 for you. That is, how would SB 45 fix the discrepancy of significantly different allowances based on what kind of long-term care a person resides in our state? The core policy of the bill is provided on page 2, subsection 1 of section 1, requires an inclusion in the state plan for Medicaid that the monthly P&A for Medicaid recipients in a skilled nursing facility must be no less than the P&A received by Medicaid waiver recipients living in a group home setting. Section 2 of Section 1 provides various definitions, and Section 2 makes certain conforming changes. Section 3 makes the bill effective upon passage and approval for performing any preparatory administrative tasks, and on January 1, 2024, for all other purposes, meaning starting this day, nursing home residents on Medicaid finally would receive an equal monthly P&A as group home residents. The physical impact. Increasing the P&A from 35 to 149 for Medicaid recipients residing in skilled nursing facilities would also impact the recipient's share of the nursing facility. If the P&A increases, the recipient's share decreases. This means that the cost covered by Nevada Medicaid would increase by $114 per recipient. I would also like to highlight the actual costs for state and county funds are less than $1 million each for the upcoming biennium. This is because the federal medical assistance percentage, or FMAP, would cover the majority of the cost of these increases. If there are questions about the physical impact, you can refer to Stacy Weeks. Closing remarks. This concludes my presentation of SB 45. It is my sincere hope that the committee sees the importance of improving the facets of quality life for seniors and other dependent long-term care services and support. Supporting this bill is an acknowledgement of our responsibility to care for vulnerable senior citizens in Nevada. Thank you for your time and consideration of this matter, and I'm happy to respond to any questions.
Thank you so much, Ms. Alvarez. Before I kick it off to my committee members for questions, I just want to remind us, we are not the Finance Committee, we are the Policy Committee, so I'll go ahead and entertain any questions. Senator Nguyen?
It is a money issue, but it is a policy question related to it. I see, obviously, there's a large dollar amount. Like, what does this mean to an individual? Like, what's the monetary amount to an individual seeking this, I guess?
Well, in the nursing home facilities, it would be an increase from $35 to $114. In the home health care, they already get that.
Okay. That's just what I wanted to confirm. Thank you.
Thank you so much. Senator Titus?
Thank you very much, and thank you for bringing this forward. It doesn't seem like there should be the discrepancy, but I just need a clarification. You used the term nursing home and then skilled facility. There's a very significant distinction between them. We know that certainly I was long-term care medical director for our nursing home in Yarrington for literally decades. Within that facility, however, we had skilled nursing beds, and we have long-term care beds. So it's my understanding, just for clarity, that the long-term care patients already received this living, and then just the skilled patients were not receiving it?
Chair, with your permission, I would like to call,
Your name for the record, please.
I'm sorry, Fran Alvarez. With your permission, Chair, I would like to call Ms. Cole, the long-term care ombudsman.
Please proceed.
Thank you, Chair Donate. Senator Titus, you are correct.
Identify yourself for the record, please.
Oh, sorry. For the record, Marie Coe, State Long-Term Care Ombudsman. Skilled nursing facilities do have residents who are there for rehab and then residents who are there for long-term care. This change would affect residents who are in the skilled nursing facilities for long-term care.
Right. Thank you for that clarity, because it is about parity, right? These folks are already same existing locations, different level of care. More care is required for the skilled patients, whether the difference is that they require some nursing care, whether it's rehab, physical therapy, wound management, something beyond just care in general, assistance with daily activities. So, but they should have the same funds for their use as I think all long-term care patients should. Can you clarify just, and maybe you have a number on, I think for folks to understand, what % of our patients in long-term care facilities are on Medicaid? Because certainly in our facility, it was the majority of the patients there.
Marie Coe, for the record, State Long-Term Care Ombudsman. Any patient, resident who is in a facility has the potential to be there long-term.
Final, there's not enough of you. Do you have more of you on the pipeline somewhere?
Marie Coe, for the record, State Long-Term Care Ombudsman. Are you asking if there is enough ombudsman?
Right.
I am happy to report we have had a significant increase in our ombudsmen throughout the state and are covering our rural areas with greater visitation. We've actually been able to increase our visits to a monthly visit for all the residents in long-term care, which has brought many issues to our attention to be able to properly advocate for them. And we are continuing to grow with the needs of our residents in long-term care.
I know it's a policy committee, so part of that policy is just wanting to thank you for what you do for this people in long-term care. Thank you.
Thank you.
Yep. Thank you so much, Senator Titus. Any other questions? Senator Stone.
Thank you, Mr. Chair, and I just want to make sure I'm understanding some things right. So at a group home, they're looking at $35. At a SNF, they're looking at $114, right? No. Could you clarify that again, please?
Thank you, Marie Coe, Long-Term Care Ombudsman, for the record. Residents in group care, which is the community care group homes in the community, are currently receiving a higher amount of spending money. Residents in skilled nursing facilities are currently receiving the $35.
Okay. So is the amount paid to each of those facilities exactly the same?
Marie Coe, for the record, the amount paid to the facilities is not the same.
It's not the same.
A significantly higher amount is paid to skilled nursing facilities. Typically, a resident in a skilled nursing facility has higher acuity than somebody in the community versus their activities of daily living. So they may have more needs, a need for a nurse versus a community setting where it would be a caregiver who is not more specifically trained. We also see people with disabilities and people who don't qualify for services in the lower levels of care due to age. So you might have somebody who has medical need that may be able to be met in the community, but the programs of support may not be available in a community, and they may be a resident at skilled nursing facility.
So this award, whether it's $35 or $114, it comes out of the gross amount that's paid on behalf of the senior citizen, correct? So if you have a higher amount that is coming out, that means that the home, the beneficiary, the remainder of the funds is going to get less. Is that going to have an impact on the availability of beds in some of these other facilities?
Marie Coe, for the record, this would not have an impact on availability of beds. I will defer to Division of Healthcare Finance and Policy regarding the financial impact of it and how that will play out, but it would not affect any available beds or licensure within the facilities.
Thank you.
Thank you so much, Senator Stone. Senator Lane, did you have a question?
Sure. I'd just like to clarify. So, because there are a lot of numbers floating around, and I think the numbers might be a little confusing. So $35 is the low end on what people are getting, the 140 or whatever it was, and 114 is the difference between the two. And so what you're trying to do is to get the people that are making the 35 whatever, the extra 114 to get on parity with the people that are getting the 140 some. Is that correct?
Marie Coe, for the record, that is correct. Residents in skilled nursing facility, that higher level of care, are currently and have since 1991 been receiving $35. There's not a process to review and increase that amount currently. It was a flat rate in 1991 and hasn't been looked at since then. The residents in a lower level of care, which are receiving a higher amount, have a different process for that amount to go to them.
Okay, thank you. I just wanted to
Thank you.
clarify for the record.
Thank you.
Thank you so much, Senator Lang. I don't think we have any other further questions. Senator Titus, one more.
Thank you for the indulgence, Mr. Chair. But I think I just can't leave this alone without clarifying, especially for Senator Stone. This is not talking about the reimbursement for the hospital for the patients to be in the facility. This is a different issue. This is their personal account that the patient gets per month that they get for their personal spending is in a separate account for them to buy personal items that they may want. They may want to go to have somebody pick something up from McDonald's. They may want to get a different shampoo, their nails done. And this is a personal account. They may want a new pajamas, something if they don't have family. So that's what this covers. This is not intended to cover the cost of them being in that facility. Just sorry I had to do that.
Thank you so much, Senator Titus. We don't have any other further questions, so I'll go ahead so thank you so much for presenting. At this point, I'll go ahead and move on to the public comment. So we'll go ahead and hear testimony in support of Senate Bill 45. Before we go into that, just a reminder that to please limit your testimony for 2 minutes. Speakers are urged to avoid repetition, and we will start with testimony and support from those in the physical locations, and then we'll go to the virtual callers. So is there anyone in Carson City that would like to provide a testimony at this time in support? Make sure you state your name for the record, and good afternoon.
My name is Tom Morley, representing Laborers Local 872 and Laborers Local 169 in Reno, and we're in support.
Good evening, Senators, members of the committee. My name is Mark Ellis, President of Local 9413, and on behalf of our retirees, we 100% support this bill.
Thank you so much. Is there anyone else we don't have anyone else here, so BPS, is there anyone in Las Vegas or virtually?
If you would like to testify in support, please press star 9 on your phone to take your place in the queue.
Hello, good evening, good afternoon. Happy Valentine's Day to all. This is Dora Martinez. I represent the DORA-MARTINEZ. I represent the Nevada Disability Peer Action Coalition, along with Nevada Council of the Blind, and we are in highly support of this bill. It is minimum for people with disability, and we hope to work with you all to make it better. Thank you so much, and have a great day. Stay warm.
Chair, there are no more callers in support at this time.
Thank you so much. Next, we'll go to opposition. Is there anyone in the room? We don't have anyone. BPS, is there anyone virtually?
There are no callers for opposition at this time.
Thank you so much. And last, we'll go to neutral. Is there anyone in neutral willing to testify? We don't have anyone virtually.
There are no callers for neutral at this time.
Thank you so much. I believe we have a motion from one of our committee members, so Vice Chair Nguyen. Oh, yep. I'll go ahead and close this hearing, but we have a motion.
Your Honor, look at that. Back in court here. I haven't switched gears quite yet. It's only day, 9? Thank you, Chair. I would move to move this to a work session today and move to pass out of committee Senate Bill 45.
Thank you so much. Do we have a second from that motion?
I'll second the motion.
We have a motion from Senator Nguyen and a seconded from Senator Titus. Any discussion on the motion to work session this? I don't have any questions. All those in favor, please say aye. Aye. Any opposed? Any abstentions? With a vote of 5 to 0 to 0, the motion passes. All right. We'll go ahead. I think that concludes for this item, so it'll move on through the legislative process. Okay, we are now officially done with this item, which brings us to the last item. Today we have the honor of welcoming our MCOs, so we'll go in alphabetical order and start with Anthem. So today they'll present on some of their plans that they've done in their work in the community, and just for logistical purposes for our members, I would recommend that you save your questions until the end as all the MCOs finish presenting, and then if there's anything specific to them, that would be the time to do so. So we'll start with Anthem. So we have Ms. Bogart and Ms. Paulson, so please begin when you are ready, and remember to introduce yourself for the record.
All right, good afternoon. For the record, my name is Lisa Bogard. I am the health plan president for Anthem Blue Cross Blue Shield and the parent company, Elevance Health. Joining me today is Emily Paulson. She is our housing program manager. Thank you, Chair Donate and members for the opportunity to present here today. So Elevance Health really brings together the concept of elevate and advance, which is really exemplified by our purpose, which is to improve the health of humanity. Elevance Health is one of the largest health benefit companies in the United States, with 1 in 8 Americans receiving coverage for their medical care through Elevance Health's affiliated plans. Through its company, family of companies, we support health at every life stage. We offer health plans, clinical, behavioral health, pharmacy, and complex care solutions that really promote a whole health approach. Our approach to health really begins with redefining health, reimagining the system, and strengthening communities together. Next slide, please. So I live and work in Nevada here locally, and I'm responsible for Anthem Blue Cross Blue Shield Nevada Medicaid business. Anthem has been providing care to Nevadans for over 50 years, and that means that 1 in 5 Nevadans carry an Anthem Blue Cross Blue Shield card. Anthem has more than 1,800 Nevadans that are employed by our organization supporting our local community and economy. And we've been a trusted state partner for over 13 years, and it really is a privilege to serve over 212,000 members currently. So our unwavering commitment really has been and continues to be to improve the health of Nevadans, and that we accomplish through our integrated care model that promotes equity and resilience. It is through really the local work and expertise, and that combined with our Elevance Health national data, research, and expertise that we've really built this industry best class approach to improving health outcomes and advancing health equity. Next slide, please. All right, so you can see here, Anthem's whole health approach aims to improve health outcomes and advance health equity. We have here listed 6 different domains. So you have maternal child health, chronic disease management, access to behavioral health, social determinants of health, which we'll spend quite a bit of time on today, going over our community reinvestments, as well as preventive and vaccines. And then we've added the rural health and network to our domains for 2023. It is really, again, and that's important to address the disparities in rural health. Strengthening all communities has a positive effect on health, and building those partnerships and really creating connections with our community partners supports whole health overall. Next slide, please. All right, so I know we only have 5 to 7 minutes, and I could probably spend an entire afternoon with you sharing all the great work that we do in the community, but I'll just focus on a few items. Maternal child health, each year we have a signature Mammarama extravaganza that supports partnering with a local company and the local community partner to bring a Mama van into specific zip codes. So bringing that service to those particularly African American and Hispanic women that don't always have the access to that care. So really bringing that service to them. We also, I'm really excited that I was able to be with Baby's Bounty when we supported them for their rural diaper bank, and I was able to give out the 2 millionth diaper. Again, just really strong partnerships supporting women in our community. In regards to workforce development, we created grants and sponsorships for UNLV and UNR, See It to Be It, and this supports scholarships for medical students. So again, we know that we are all working towards trying to make sure that we have enough providers in our state to be able to provide the care that that Nevadans need. All right. And then lastly, I just wanted to say that we've spent, since 2017, we have focused on a program called Anthem Pathways. And each year we provide support, and it includes housing, back up one please. And it provides housing, wraparound services for those inmates that are exiting parole and probation from our justice system. And so this opportunity has just been really effective in regards to reduction of recidivism rates. Our current recidivism rate for these programs is 5%, which is really impressive for the program, and we are really pleased to continue that each and every year. And then lastly, I'm going to turn it over to Emily to talk about our stable housing program. And at Anthem, we absolutely believe that housing is health. And so I'll turn it over to Emily.
Hi, good afternoon. My name is Emily Paulson. For the record, I have the privilege to serve as the Housing Program Manager at Anthem Nevada Medicaid. Thank you, Chair Donate, and members of the committee for allowing me to share some more information about what we're doing to provide housing as a healthcare benefit. At Anthem, we understand how central stable housing is to our members' whole health needs, and we've launched a cross-system strategy that offers an array of housing interventions for our members depending on the acuity of their need. So our housing interventions, as you can see on the screen, include housing problem solving, homeless prevention and diversion, emergency housing, transitional housing, and permanent supportive housing. Each of our housing programs integrates physical and behavioral health care management with housing-focused case management, so members benefit from interdisciplinary support and care. We know housing our members experiencing homelessness transforms their lives by providing safety, stability, and wraparound support to access physical and behavioral health services, which ultimately reduces ER use and inpatient stays. In our supportive housing programs, which serve our higher acuity members, cost studies have shown up to $2,300 in savings per member per month from reductions in ER and inpatient utilization. Providing housing as healthcare is not a new endeavor for Anthem Nevada Medicaid. We were the first MCO in the state to offer value-added housing benefits, and we've been doing so since 2016. In 2022, we significantly increased our community reinvestment into our housing continuum by launching new programs, investing approximately $4.5 million into housing programs, which exceeds our 3% contract requirement. These efforts provided housing supports to over 1,800 of our Anthem Nevada Medicaid members experiencing homelessness or housing insecurity. I also just want to take a very quick moment to share just a quick story about one of our members who, in the year before he was housed into our permanent supportive housing program, visited the ER 353 times. So Senator Stone, just speaking to the question you had for the Nevada Hospital Association, that member, after being in housing just 6 months, he stopped utilizing the ER for services and spent actually a whole year without visiting the ER even once, because he was able to get connected to the right providers for the right care at the right time because he had the stability of housing. So supportive housing works, and we're investing in that as a healthcare resource. Thank you.
For the record, Lisa Bogard. So really in closing, we're incredibly proud to be a part of this community, and the community reinvestments that we make are aligned with our state partners' priorities. We are dedicated and focused on improving the health of Nevadans. And on the last slide, if we could just sorry. Just wanted to call out a couple of items that we were the first in Nevada to achieve the NCQA Health Equity Accreditation, and we're very proud of that. We also, previously to that, we were also the first for the multicultural accreditation or distinction. So it's really important to us as we look and listen to our members, our providers, and our community organizations, that we really take into account their needs in this process with the community reinvestment, because we all have to work together in order to make this successful. Thank you.
Thank you so much, Ms. Bogard. So just for the committee members, if you have specific questions for Anthem, you can ask them now. But if they're MCO questions, I would prefer that you wait until the end when they all present. So do we have any specific questions for them? Senator Nguyen.
Oh, and everyone else can listen up because I'm probably going to ask the same question of everyone. We had talked about, or you had talked about the community investment funds, so that 3%. And I know that in our conversations before this committee meeting, you had mentioned that you actually exceed that investment. Can you tell me what those actual dollar amounts amount to in our communities here in the state?
Yeah, so I don't have the exact number with me, but what I can tell you is that we spent $4.5 million on our housing programs in 2022, and that exceeds that alone, plus our other value-added services and benefits that we provide to our members.
Can you give an example of some of those value-added benefits that are like maybe unique to your program?
So we make sure that we are tying in the member incentives, for example, to our quality results. So if a member, or actually I'll do the provider side first, the provider, we incentivize them for providing services postpartum. So there's incentive for the provider there. There's an incentive, during the COVID timeframe, we had a $100 member incentive to make sure that, again, we were trying to promote that. We also have that for vaccines. So some of the unique items that we're proposing for this year comes in regards to food as medicine, so providing postpartum meals for mothers. We have a very robust pregnancy benefit that we give a car seat and multiple items to members that they can choose from.
Thank you.
Thank you, Senator Nguyen. Any other specific questions? We don't have any now, but we might come back later. So thank you so much.
Thank you.
We'll go ahead and proceed to our next presentation. So we'll go with the members of Health Plan of Nevada. So Ms. Simonson, who is the plan president, please begin when you're ready.
Good afternoon. For the record, Kelly Simonson. I'm the plan president for Health Plan of Nevada's Medicaid plan. And I've actually been serving in this capacity for the last 25 years. Health Plan of Nevada has a long history of serving our members in our state. We have recently celebrated our 40th year of taking care of Nevadans. And for the last 26 years, we have been serving Nevada Medicaid recipients. We are the only insurance company that has been contracted with the Division of Healthcare Financing and Policy since the inception of Medicaid managed care in 1997. And we joined then at the request of Governor Miller, not because there was a lot of membership to be had. It was voluntary enrollment at that time when we started with one member, but we knew that we could bring mainstream medical services and healthcare services to individuals in the Medicaid arena, just as we had been for our commercial members. And we've gained a lot of information and knowledge about our Medicaid members over the last 2.5 decades. We've listened to our members, we understand their needs, what they need for their healthcare services, and we've built programs and a network around those needs to serve their healthcare. So what we see as a result is that when members have a choice, they very often choose our health plan. And a good example of this is in 2022, the state redistributed the membership with the new contract that started in January of 2022. And so members were moved so that each plan started with 25% market share. And in the 3 months that followed the redistribution, we saw that approximately 50,000 members returned to our plan, which was 2 times the number that had returned to any other previous plan. Today, we enroll about 232,000 members in Clark and Washoe County, which represents the largest number of market share in the state at about 32%. Health Plan of Nevada is part of our parent company, United Healthcare, and through United Healthcare and our overarching umbrella of United Health Group, we employ approximately 6,600 Nevadans who volunteer about 83,000 hours per year, and we make significant investments in our community, which I'll go over at the next slide. We've had a significant focus on our provider network, and I'm pleased to say that we offer more than 10,000 unique providers to service our Medicaid members in Clark and Washoe counties. Hallmark to our plan is our really comprehensive clinical program that is overseen by our chief medical officers and our behavioral health chief medical officer, who oversee 350 clinical staff who live and work in Nevada and follow our members through their healthcare journey from the inpatient setting to the outpatient setting, ensuring that they receive the right care at the right time in the right setting. And complementary to our clinical programs are our social determinant of health programs. Research shows that 85% of the factors that impact a person's health happen completely outside the healthcare setting, and those are the social determinants of health: food, housing, transportation, and employment and security. And so we've built programs to address those needs for our members. Our housing program originally launched in 2015, and we have continued to build that over the years to transitional housing, long-term supportive housing, sober living housing, and medical respite. We have a complement of community health workers that we launched in 2015 who are field-based workers who go into the communities, meet with our members to close those gaps in social determinants of health so that individuals can then focus on their healthcare needs and not be burdened by issues such as insecure housing and insecure food. When we look at social determinants of health, of course, we also have to look at health equity programs. We have several programs that are available to our members to address those disparities in healthcare. For example, we have a doula program that we launched a couple of years ago, and when we look at the birth outcomes for African American women in that program, we are seeing that 92% of the babies born in that program are born at a full-term birth gestation of about 37 weeks and greater. We also have a vaccine navigator program that focuses on minority communities and childhood immunization rates, and we're seeing nice increases in vaccine rates for particularly the Latino community. Our entire health plan is really built on the foundation of quality, and I'm pleased to say that Health Plan of Nevada is the highest rated NCQA Medicaid managed care plan available in Nevada. And that is based on our quality scores for HEDIS and our satisfaction scores on the Consumer Assessment of Health Plan surveys. So when we look at our priorities on how to improve our health for our members, we really look at 4 different areas. Access to care is a significant priority. We all know that we live in a state that has a workforce shortage for healthcare. And when we couple that with the social determinants of health that impact our Medicaid members, we've had to launch additional programs to serve our members where they live. So we've launched a mobile clinic through our Medicine on the Move. We partner with other mobile clinics in the community. We have home care programs where we send practitioners to the home. Of course, telehealth is always an option for members. And we're focusing on integrated care sites where members can receive their behavioral and their medical services in the same setting. And this year, we have an opportunity to invest in primary care services. So we are developing a plan to partner with provider groups to help them engage in recruiting efforts to bring more physicians to the state and develop additional programs for primary care that will be available to Medicaid recipients. We welcome any opportunity to increase flexibilities around telehealth so that providers who have licenses in other states can practice here in Nevada beyond when the PHE ends. And also any opportunities to streamline the professional licensure processes so that when, for example, physicians who are moving here to Nevada can receive somewhat of an expedited process to receive their physician license here in Nevada. Behavioral health is a second tenet that we really are focused on. Network expansion. Since 2020, we have really focused on expanding our network by about 170%. We've recently transitioned from a capitated agreement with a provider group in Southern Nevada to a fee-for-service program and expanded our network and are continuing to do so. But it's also beyond the network. It's really looking at programs that are needed in our communities. So we're continuing to build out our peer support specialist program, our recovery and resiliency program, and building out the crisis continuum of care model with internal and external partners that are needed in our communities. And we're really excited to see that the Division of Healthcare Financing and Policy submitted a substance use disorder waiver program that we're waiting for CMS approval, and that will allow for residential care for people who are afflicted with addiction issues. And then, of course, social determinants of health, I've already mentioned some of that, but one piece to point out is that we can't just put a roof over someone's head and expect that they will be fine. These are individuals who need a lot of support and a lot of wraparound services that we've been doing at the health plan for the last 7 or 8 years. So to complement that, again, the division has recently submitted a tenancy support program to CMS for approval, and we are anticipating when that is approved and finalized that will help further build out those tenancy support services that individuals need to eventually gain self-sufficiency and potentially move off Medicaid. We offer transportation benefits to our members above and beyond the MTM benefit to medical appointments, social service appointments, and behavioral health appointments, and we have a variety of food security programs, And then, of course, I think everyone knows about Medicaid redeterminations, and we are really focused in partnering with the state to mitigate the uninsured rate from that potentially increasing. So we have been working to update demographic information with the state on our members, involving community-based organizations and providers to educate them on redetermination so that when they interact with Medicaid recipients, they are able to educate them on the process of how to redetermine. And we have a long legacy of giving back to our community. If you see on the left-hand side of the screen, you'll see our large, sometimes single, but mostly multi-year investments that we've made with community-based organizations here in Nevada. These come from our parent organization, United Health Group, and they range anywhere from $250,000 to $25 million. And these are really focused on increasing the healthcare workforce through the grant to the UNLV School of Medicine and Toro University, and then areas around housing with our commitment to Chicanos por la Casas. And then on the right-hand side of the screen, you'll see our 2022 charitable giving, which is the 3% community reinvestment dollars. We are well over $2 million right now and continuing to count. We'll probably be heading more towards $3 million, but that has been invested in about over 100 community-based organizations. I'd just like to end with the value of Medicaid managed care and just really quickly what we bring to our state and to the Medicaid program. Budget predictability. So we know that the state is able to transfer the claims cost risk to the health plans for fixed payment. And then in addition to that, there are guardrails around profits and losses for managed care plans. There is the 85% MLR rule, which is the federal law that's been in place, I believe, since 2017. And that means that if we spend less than 85 cents for every dollar of revenue that we receive, we have to rebate that money back to the state. Similarly, the state has risk corridors that have been in place for the last number of years, where there's also a targeted MLR, and if we do not reach that MLR, meaning we don't spend enough money taking care of our members, then we have to rebate that money back to the state. Sorry. Drink of water. And then there's a premium tax revenue benefit that the state gets, where we pay 3.5% to back to the state for premium tax that we can then it's our understanding then that the state can receive federal matching dollars for those programs. Healthcare improvement. We are required, it is our job to improve healthcare, and there are many ways that the state measures us on that. HEDIS is one example, performance improvement projects, pay for performance, where the state withholds a certain percentage of our premium, and we have an opportunity to win that back if we meet the targeted goals. Member satisfaction is another area where we are measured through our CAP survey annually. And we, of course, have member services, case management, over 350 clinicians available to help our members, our community health workers in the field, and our value-added benefits. Those are items such as, we mentioned, housing, food programs, transportation programs. We offer a Walmart benefit, which helps people to get gas and at a discounted rate, and also can help them get their food. And all of that is offered outside of the Medicaid managed care capitation rates. And then, of course, access to health care. So we have access and availability requirements in our contract that the state monitors us closely on that. It is our responsibility to get our members into care. One way we do that is through value-based contracts, where we can reimburse providers additionally for quality services. And that tends to open more appointments for our members. We also can do appointment scheduling for our members directly into some providers' scheduling systems, and we're continuing to build that out this year. So we take that burden away from the members, and I've already mentioned the primary care investments we'll be conducting this year. And that really concludes our presentation. Thank you.
Thank you so much. I will go ahead if there are specific questions. Senator Nguyen.
Hi, thank you so much for that presentation. Again, I obviously have an interest in some of the community investment dollars, and I appreciate you kind of answering some of those questions before I had to ask them, I do have a question about like what the process is on whether or not within and amongst the MCOs, if there's a coordination of how you are reinvesting those funds into the community. You mentioned a couple of like organizations and nonprofits around housing. Like, how are those organizations selected? Is there input within the community to make that determination? Just kind of the thought process. I know that I work a lot with my city councilman, Brian Knudsen, in the city of Las Vegas, and my county commissioner, Tick Stegerbloom, trying to figure out how we can coordinate within the different agencies to, like, you know, tackle housing issues and homelessness issues. So I'm very curious to see what you do within your industry to do that.
For the record, Kelly Simonson. Yes, absolutely. So in terms of coordination, we meet regularly with community-based organizations, but we currently, our process is that we have a form that when we work with community-based organizations, we have them fill that out, describing the program that they are asking funds for, and then we vet that internally to see if it would meet the needs of our members. So that's how we currently are operating the community reinvestment dollars. We really make sure we're focusing on access to care and social determinants of health are really the two areas that we believe are most impactful. I recently, just today, in terms of your question on how we coordinate as MCOs, I think an example is the Northern Nevada Food Bank is now offering sessions where all the MCOs come together, and people are invited from the community where they can learn about what Medicaid is, how to obtain their benefits, what services are available. And we spoke with the Northern Nevada Food Bank today about more of a community-wide effort where perhaps all the MCOs could come together and provide services designed to help the entire community.
Thank you, and I'll probably follow up with all the different MCOs just about that subject.
Thank you so much. Senator Titus.
Thank you, Mr. Chair, and thank you for the presentation. You mentioned Washoe and Clark County. Do you offer your programs throughout the state and all the counties?
For the record, Kelly Simonson, we do not currently. Our service area for Medicaid is just Clark and Washoe County currently.
Thank you. You mentioned increased telehealth flexibilities, and it kind of raised a little bit of a question that I have. And then you mentioned for providers not licensed in the state of Nevada to be able to provide this. Can you clarify that for me?
Absolutely. So again, Kelly Simonson for the record. So we were looking at providers who are licensed in another state who could provide telehealth services to Medicaid recipients. So for example, pediatric subspecialties that are very limited in Nevada, it would be helpful if we could have those providers who, for example, are licensed in California, conduct telehealth visits.
I would be really anxious to see if I might follow up on that, Mr. Chair. Just that I have great concerns when you talk about telehealth for non-licensed Nevada providers, and I worry about our bricks and mortar providers here who've established cares, established patient relationship, and then being undermined by contracts with providers that don't have that facilities in the state of Nevada, and would like to see more on what you plan on that one. And certainly if it's a very unique specialty, they're not here, and the provider needs to consult with a specialist somewhere and looking at that possible reimbursement. But it would be, I have grave concerns contracting with a non-licensed provider that's not in the state of Nevada, especially if we have the services in the state of Nevada, just because you can pay them less. So I'd be really anxious to hear that model and future discussion on that subject. Thank you.
Thank you so much, Senator Titus. I have a quick question specifically on slide 5 in terms of the 2022 primary care investments. you mentioned value-based contracting. What has been the feedback that you've received in the community as a transition towards that? Is it being receptive? Are you still working through what the quality metrics will be? I'd like to hear a feedback on that.
Sure, absolutely. Again, Kelly Simonson for the record. Yes, so overall, the feedback is very positive from providers. They, you know, they are concerned about the Medicaid fee schedule meeting, you know, their costs, and so the additional reimbursement is very welcome. We find a lot of times they are providing the services. Sometimes it's a coding issue, sometimes it's a staffing issue, and so the additional dollars are helpful for them to perhaps close that gap in the revenue. So, but yes, positive feedback.
Great, thank you so much. Any other specific questions? We don't have any, so we'll come back if we do. Next, we'll move on to Molina Healthcare. We have Mr. Rob Bowman, who is the plan president. So please proceed when you're ready.
Senator Donate, members of the committee, really appreciate the opportunity to be here this afternoon. My name is Rob Boffman, and I'm here on behalf of Molina Healthcare of Nevada. Also, not only the plan president, but also going to be doing the AV work here today. So hopefully we're live and on the screen for everybody at this point. All right, so Molina, while we may be the new kid on the block here in the state of Nevada, having served the members here now for 13 months, we've been in business for over 40 years, driven by our mission to improve the health and lives of our members by delivering high-quality health care. You may be aware, I am recently joined the Molina family 2 months ago, so very, very new with the team, and really have to say that the Molina values were a huge part of the reason that I chose to join the organization, and can verify now 2 months in. We practice what we preach, and really, call out the member and community focused. With dedicated resources, and we'll touch on this in a little bit, really excited about our community reinvestments, really, a core focus in the organization on that member as well as that community element. Just going to hit on some of the highlights. Molina Healthcare of Nevada here. We do serve over 118,000 Nevadans in Medicaid. We also launched at the beginning of this year our Medicare program and are planning on rolling out Marketplace 1/1/2024. We have physical locations in the north and in the south, and also very excited to share that we launched our mobile help unit, which you can see is this beautiful wrapped RV here, just this past month, which the game plan is to be able to provide service in the communities where our members live to help address challenges as it relates to transportation and access to care. We have about 250 employees housed throughout the state. In addition, we've got over 25 value-added benefits that we offer to our members through our programs. Quickly highlighting, some of the kind of key opportunities, challenges that we'll face in this year. Redeterminations. On joining the organization, really made sure that my leadership team had a pure focus on the redetermination effort. My goal was that it needed to be top of mind for all of my leadership team and subsequently their staff, because at the end of the day, this is a situation that we have never encountered before anywhere in the entire U.S., let alone in the state. And so, this is an opportunity for us to make sure that we can do our best to ensure that members who are currently on our rolls, receive that mail that comes in for the redetermination process, are enabled to successfully re-enroll in the program when that time comes for them. Really approaching this with a partnership element and aspect, so working with providers, working with community-based organizations, direct within our own organization, any contact points that we're having with our members. We've rolled out call center initiatives where individuals can call in. We're directing them back to the state, making sure that folks are aware to update their contact information proactively versus waiting until, oops, I didn't receive my letter. Now we're in a crisis mode to make sure that we can get them back on the rolls for coverage. Value-based arrangements, that is another big area for our organization. Really proud to state that we now have over 80% of our membership enrolled with PCPs who are part of our value-based arrangements. That's hugely impactful. This goes beyond just participating in a fee-for-service environment to really incentivizing the providers to be focused on the outcomes. So, that member who is on their panel who's a diabetic, are they actually testing? Where's their HbA1c? Are they getting the supports to be successful in managing that disease state? Trying to keep us on time with the allotted time frame here. Going to focus now on our community-based reinvestments. So perfect timing here in terms of what activity is going on. And quite frankly, personally, very excited about this piece because I've been able to personally participate in some of the phone calls announcing to our community-based partners some of these grants that we're doing as part of this initiative. So again, being the new kid on the block, we're rolling out $1.2 million of investment specific to this program. And just so folks are aware, this community reinvestment program, if you're not familiar with it, is intended to serve the greater population, so not specific to our membership. So we are really approaching this with a population health mentality. Project Echo, for example, working with the provider community. Really excited about working with one of our partners in the Las Vegas area who support the veteran community and homelessness, Share Village, and doing a sizable grant to them. And really, at the end of the day, approaching things from looking at it on the social determinants of health, homelessness, behavioral health, really carrying those themes forward into our grants this year, and then looking at how those can be impactful in the coming year. So is it continued investment with these programs for 2023, or are there other community-based organizations that we can continue to partnership and just make a tremendous impact on the population of our state? So with that, I'm going to go ahead and wrap up.
Thank you so much, Mr. Boffman. Can you go back to the other slide?
Absolutely.
What are some of the details that you guys are doing in terms of addressing the homeless issue and housing?
Yeah. So, we do have as part of our value-based arrangements, our value-based program, value-added benefits, semantics. Value-added benefits, we do have a housing program in the north and in the south where we have contracted with providers to provide beds. So that's for our specific membership population. For the community in general, investments in group like Share Village to provide for, again, the general population. We benefit that, everybody benefits. And for the record, Rob Boffman.
Thank you. Any questions specifically to Molina? Senator Stone?
Thank you. Nice to see you. Could you just kind of elaborate on your, mental health is a big issue for us here in Nevada. Can you talk about the kind of professionals that you have that are delivering mental health services here? Are you employing psychiatrists, psychologists, or MFTs?
Yeah.
Or all the above?
So employed.
Name for the record, please.
For the record, Rob Boffman. On the employed side, we do have a psychologist on staff. I'll get further details for you for the makeup of the addition of our behavioral health staff, though. We'll follow up with that.
Senator Titus?
Thank you, Mr. Chair, and I would be remiss if I didn't look out for my rural counties. So who do you are you in Clark and Washoe or throughout the state?
For the record, Rob Boffman. So we are in Clark and Washoe. Those are the service areas for the Medicaid program. On the Medicare side, we're also in those counties, but looking to expand for 2023 into Nye and to Carson City. And then for our marketplace offering will be Clark, Washoe, as well as Nye, and looking at Carson City as well.
Thank you. Thank you, Mr. Chair.
Thank you so much. Any other questions? And I was remiss to mention that we do have a representative from Nevada Medicaid. So when we open up the questions at the end of the presentations, we can ask for clarifying questions as well. Okay, thank you so much, Mr. Boffman. And then last but not least, we will have a presentation from Silver Summit Health Plan. So Mr. Schmacker, when you are ready, please proceed.
Sorry, looking for the. Stick. See it? It's right here. Oh, yeah. I just thought it was. We're good. Thank you.
You can go ahead and begin. We have the exhibits online as well. So.
Thank you, Mr. Chair. Mr. Chair, Eric Schmacher, CEO of Silver Summit Health Plan. Last name is Schmacker. I have with me Nikki King, our Vice President of Community Solutions. Thank you so much for allowing us to be here today to provide an overview of Silver Summit Health Plan and to provide you some information reference our community investment program. So Silver Summit Health Plan is a wholly owned subsidiary of Centene Corporation. Centene is headquartered in St. Louis and is the country's largest provider of government-sponsored health insurance with over 26 million insured across the country. Silver Summit Health Plan in particular is here serving the state of Nevada with the Medicaid program. We're one of the 4 MCOs in Clark and Washoe County. We also have a marketplace product known as Ambetter, which is statewide in every single county, and we also have a Medicare Advantage program. We have 180 plus employees here in the state of Nevada living in Las Vegas and Reno, but backed up by over 70,000 employees nationwide that are supporting us also in our mission, which is transforming the health of the community one member at a time. It is important to note that we recently received our accreditation from NCQA for health equity. Health equity is woven through the fabric of every single department within the health plan and is a foundational piece of what we do every day and is part of our DNA. Next slide.
No, that slide.
One back. Yeah. Everything we do at Silver Summit Health Plan focuses on our members. They are the center of everything we do. We focus on the whole health of our members through our integrated behavioral health, provider, and community networks. When building a network, we don't just focus on time, distance, or provider type. We also focus on other factors such as ethnicity, race, gender, so our members can see providers that they are aligned with and with which they feel comfortable. We continually manage and assess our network to ensure standards are being met and our members have access to high-quality providers. Finally, we sustain and mature our network through working with providers on value-based agreements and helping expand their services. Next slide. I would like to highlight how we focus on providing access to quality care for our members. First, in behavioral health, Silver Summit has immediate same-day appointments 7 days a week and guaranteed crisis talk therapy appointments for any crisis or urgent needs. In our provider network, we have an accelerated breast cancer treatment program. This is a population health program developed by Silver Summit Health Plan to improve survival for women diagnosed with breast cancer by eliminating delays in and between diagnosis and treatment. We are also working closely with our providers to expand access. For example, we are working with Annette Logan at Cure for Kids to assist in recruiting and funding a pediatric rheumatologist. Similarly, we are working with Dr. Medina Gomez of the Southern Nevada Infectious Disease Society to help fund an infectious disease fellowship program. We provided a $500,000 grant to REACH to partially fund a clinic in a largely Hispanic community. REACH is a not-for-profit focused on access to care in Nevada. This funding for this clinic will help reduce health disparities in the Hispanic community by providing them an access point to providers that they trust. The FQHCs are vital to providing access to care in our communities and for our members. We provided a $500,000 grant to Nevada Health Center to expand into Washoe County, where they have never had a clinic. We provided $200,000 in funding to HOPES to help fund another clinic location in Reno. Lastly, we are working with Project ECHO to fund continuing education for our providers. One of the 2 ECHOs that we funded this year is on Transgender ECHO Project. I'll now turn it over to Nikki King, our Vice President of Community Solutions, to talk about our provider network.
Thank you, Eric. Nikki King for the record. We also focus our efforts on increasing access points within our community network, which is comprised of agencies that provide the services our members need outside of the provider office, like food banks and housing. We invested $500,000 in Baby's Bounty so they could expand their program to Washoe County and the northern rural counties. We increased access to healthy food through our investment in the Just One project in Las Vegas, which has allowed them to expand their community market to serve twice as many people and offer evening hours for the first time. And in Washoe County, Catholic Charities received $600,000 to open a new community market on the corner of Kitski and Moana, and for the first time offer Saturday hours. We addressed a huge gap in homeless services in Washoe County, investing $1 million in our Life Changes Healing Home, which provides non-medical respite care. This home offers Silver Summit members experiencing homelessness a safe place to discharge from the hospital and receive home health care after either an illness or injury. And our most ambitious project to date, the permanent supportive housing complex we aim to develop in Las Vegas, will have roughly 150 studio, 1, 2, and 3-bedroom options, workforce development, child care, a community market, case management, and Nevada Health Centers will have a full-service clinic, all inside the facility. In these ways and more, we increase and expand access to services in our community network. Next slide, please. We understand that how we give is just as important as how much we give. We have set up a mini foundation at Silver Summit with an open application process, including a review committee that has community and Silver Summit members on it to score and select the awardees. You can see on this slide that we have invested over $9 million in 2022, which far exceeds the 3% requirement. These are, next slide, please. These are the areas that we funded, which align with our state partners' priorities, the Medicaid Reinvestment Advisory Committee recommendations, and our members' needs. We know you are really interested in understanding our investment program, so we have provided more information in the appendix of this presentation. And I'll now pass it back to Eric to address our outcomes.
For the record, Eric Schmacher, I would like to share some outcomes that we've achieved over the past several years. As you can see, we are making significant improvements in quality of care in our behavioral health network. This is largely achieved through a comprehensive, integrated approach focused on the whole health of our members, including their social determinant of health needs. We are very focused on improving maternal and child outcomes. We put an initiative in place to improve the communication with our providers, resulting in an improvement in the notification of pregnancy process. Our care management team reviews these notifications, identifies medium and high-risk pregnancies, and enrolls those individuals in our nationally recognized Smart Start for Your Baby program. Silver Summit initiated a remote patient monitoring program, which provides members with technology that monitors various vital statistics and automatically sends that information to a clinical team that can immediately address routine, urgent, and critical care needs. Lastly, we anticipate a 20% increase in the survival rates through the Accelerated Breast Cancer Treatment Program.
We have many Nikki King, for the record. We have many aspects to our housing program, but one that is delivering results is our partnership with Clark County and Help of Southern Nevada. This program provides housing support and wraparound services for up to 2 years for qualified members. Through this approach, our members have reduced their ER utilization by 96% while increasing their utilization to primary and specialty care services. The Teen Suicide Prevention public health campaign we funded and conducted in partnership with Hope Means Nevada and the Nevada Office of Suicide Prevention targeted both teens and their parents earning less than $50,000 a year in Washoe and Clark counties. The purpose of this $1.5 million investment was to drive awareness about the mental health resources that are available, many of them for free. The data shows that this campaign performed equally among teens and parents and English and Spanish audiences. These 4,000 interventions included a 30% increase to the NAMI phone line, with the primary user of that intervention being Hispanic parents. The Trevor Project, which is the dedicated crisis line for the LGBTQ community, received 300 calls and 106 texts. At Silver Summit, our primary BH provider saw a 32% increase for new therapy appointments. Why does this matter? Because studies indicate that if people are seeking mental health care, they are less likely to attempt suicide. Finally, we've provided the funding for 6 Silver Summit women members to receive scholarships from the Nevada Women's Fund. The average amount of the scholarship will pay for an entire year of tuition for many of the recipients. And as you can see on the screen, they are each pursuing degrees that will allow them to give back to the community. This investment not only impacts our members, but their entire family. It's these types of investments that enable Silver Summit to meet our mission of transforming the health of the community, one member at a time. Next slide, please. Thank you very much for the opportunity to present, and we'll answer any questions you may have, Mr. Chairman.
Thank you so much. I'll go ahead and start with the first question. Regarding your selection committee members, is there a timeline as to what the term is that they serve on this committee? Is there a diversity requirement that you look on as to who are the members that you try to engage in their backgrounds? What's the process behind that?
So the selection committee is made up of 5 Silver Summit Health Plan staff, 2 community members. This year we had Sheila Leslie from Washoe County. I don't know if any of you remember her, but she was a state senator for many years. She has a lot of experience in granting funding. And then Kim Riggs from the Department of Welfare and Social Services. So why did we select them? Because they understand the nonprofit world and they understand the services and the importance of them. So then we also have 2 Silver Summit members on the committee as well. So our process is that we built this foundation because we come up alongside the nonprofits just like they're used to, right? They're used to submitting grants and having a timeline. So it's all on our website, all very transparent. They submit a proposal, and we created a rubric where, so the scoring was very fair. And then we read all the applications, 62 applications totaling $22 million, and then scored them based on the priorities that I listed and how, and also their track record.
Thank you. And just a follow-up question, because you do operate from the foundation-like sort of status, do you keep track of the applications that get rejected as they go through the application process? And does your staff either in the selection committee or as part of Silver Summit, do you help folks into reapplying and making their application better?
Yes, absolutely. So we have, we provided technical assistance, and so we put that very plainly on the website, and I got many phone calls, and I talked people through exactly what we were looking for. I told them, we need to address health disparities. Health equity is really important. So again, we were really transparent. Particularly also because we funded many providers and they don't have grant writers on staff. So we were very fair as well, handicapping those applications.
Thank you. Any questions from committee members? Senator Titus.
All right, where do you cover? What counties?
Washoe and Clark.
For the record, Eric Schmacher, So on the Medicaid side, of course, the managed care organizations only have coverage in Clark and Washoe counties. Now, with our And Better product, we are statewide in every single county rather, statewide. Medicare Advantage, we're in Clark, Washoe, and several surrounding counties.
Okay. On one, you didn't number your pages that at least I can't see. Oh, maybe page 7. I see it now. You talk about some outcomes, and you talk about mention provider network and maternal child health with a 53% reduction in neonatal ICU days. Can you maybe give a little bit more input to me on how, what are you using to give that kind of figure? Is that across all patients that you saw, that every single mother that you've had enrolled in your maternal child health? And if so, what would you say was the reason that you had those kind of improved outcomes?
Yes, for the record, Eric Schmacher, Chair, through you to the Senator. So the foundation of these improvements was based on improving our notification of pregnancy process, whereby the earlier that we know that an individual, one of our members, is pregnant, and we have them conduct an assessment, those that are medium and high risk are placed into our Smart Start for Your Baby program. Part of this program, we have nurses that have training in OB, postpartum care, and neonatal intensive care. They navigate that member of ours, that pregnant member of ours, through various services, working with their OB provider to ensure they're accessing care, accessing prenatal care, and trying to keep them as healthy as possible during the course of their pregnancy. So that is the program that we use, and we've achieved these outcomes over the time period that you see here with the reduction in neonatal intensive care days.
Thank you for that, because it's actually huge, because one of the costs that we see is these neonatal ICU days. So anytime we can limit those, improve outcomes on not only just ICU days, but then that child now has a better overall record, goes to kindergarten, advances, and it's just better overall. So thank you. Thank you.
Thank you, Senator Titus. Senator Stone.
Thank you, Mr. Chair, and thank you for the presentation. A few things kind of impressed with accelerated breast cancer detection and treatment. Obviously, early detection is very important for better outcomes. Not only that, but just the psychology of the patient. When they find out they have a lump, they're scared to death. They go get it biopsied. It's malignant, and now they got to wait 2 months to see an oncologist. Tell me how your program accelerates this process where after a diagnosis they're in to see an oncologist and treatment begins. What kind of a time period are we looking at?
For the record, Mr. Chair, for the record, Eric Schmacher, Mr. Chair, through you to the Senator. Dr. Evans, our Chief Medical Officer for the health plan, is very passionate about breast cancer treatment. And he noted that there was not just within Silver Summit Health Plan, but for all Nevadans, a delay between the time they're diagnosed or receive a mammogram to the time of treatment. The longer that delay is, the worse the survivability of the patient. So what we've done is created a navigated approach whereby every single day we're reviewing mammography screenings, identifying those that are potentially positive, so questionable or positive, and we're streamlining the process to get them into a provider through a navigator that is hand-holding them through the process, all the way through getting them back in for further testing or to getting them to a surgeon, and all the while we're communicating back to their PCP to make sure that they're tied into the process. So our goal is to greatly reduce that timeline to maximize and increase the survivability for the patient.
Well, I'm impressed with that, and I'm impressed with your results on that. Behavioral health is a top priority for many of us on the dais here. Psychiatric appointments in 24 hours. Is that through telehealth, or is that a live-to-live therapy session?
Yeah. For the record, Eric Schmacher, through you, Chair, to the Senator. we work with our behavioral provider network, and we pre-purchase appointments with a live provider to ensure that our members are getting access for that care.
And is that provider a psychiatrist, a psychologist, MFT? In most cases, what are they saying?
In most cases, a psychiatrist, but depending on the needs of the patient, they're navigated to the appropriate provider type.
That's pretty impressive within 24 hours, I have to say. And then lastly, your telehealth network. Is that network kind of following Senator Titus's questioning? Are those Nevada providers, or are we using a national network of physicians to have telehealth sessions with our patients?
For the record, Eric Schmacher, Chair, through you to the Senator. We partner with two contractors to provide telehealth services. The vast majority of the providers are in the state, but with some of the freedom that we've had over the course of the pandemic, some of the providers have been out of state. We are working to make sure that with any change in law that of course they're seeing in-state providers.
Are the providers that are being sought out of state for financial savings to the plan, or is it because we don't have those specialties here in Nevada?
For the record, Eric Schmacher, through you, Chair, to the Senator, it's really a combination of both, making sure that we can provide access to telehealth services 24/7. And if that can't be achieved with the providers here in the state, then of course we're having to access providers out of state.
Okay. Thank you. I appreciate the answers. I support Senator Titus's passion, and it's a passion of mine that we need to make sure our physicians in Nevada are given the opportunities to participate in the health plans, because we're trying to nurture a growth of physicians here, and if we're just relegating that to other states, we're not going to be fixing our physician problem here in Nevada. But thank you for your presentation.
Yes, sir. Understood.
Thank you so much, Senator Stone. Any other further questions? I think we conclude with this presentation. At this time, I'll go ahead and invite back just the plan president. So, Mr. Schmacher, you can stay behind. And committee members, do we have any questions just in general for any of the MCOs? We also have Nevada Medicaid if we'd like to invite them for any questions specifically to them. Never mind. I think we're pretty good. So we don't have any other questions. So I think it was helpful that we asked the individual ones and so forth. So we'll conclude these presentations. You know, as part of the rationale as to why we did this, I think it's important to understand that some of the work that we do in healthcare needs to address the social determinants. After all, you know, our goal is to improve public health, and it's important not just for you all as MCOs to share the work that you do individually and some of the priorities that you have, but also for the committee members to understand and how that relates to the public policy that we pass. So thank you so much for presenting that, for visiting us here today, and we will be excited to continue forth in passing policies. With that, we have reached the end of the meeting. We'll go to public comment. So we'll go to public comment here in the physical locations, and then we'll go to anyone who has called in. So just a reminder to please limit your comments to 2 minutes. Is there anyone in Carson City who would like to provide public comment at this time? We don't have anyone here. BPS, is there anyone virtually?
Chair, the public line is open and working. However, there are no callers at this time.
Thank you so much. We'll go ahead and close public comment. Again, thank you to all our presenters, of course, to the Hospital Association, Mr. Kelly, and to all the MCOs who presented here today. We graciously appreciate your service and all the information that you can provide. So thank you again, and the meeting is now adjourned.